try and keep up with the targets you're being set by the waiting time targets going up and trying to sort of fight those. At the same time, you've got new technology coming at you, and the managers, some of whom are very capable in the NHS, spend their time doing the here and now and not looking at the strategic development of the service because of the pressures on the immediacy. And that's a major problem we have.
Mr. Shattuck.
Mr. Chairman, let's see. There we go. Can you hear me now? Thank you, Mr. Chairman, for holding this hearing. I think it is tragic. I serve on the Energy and Commerce Committee, and we have not heard testimony anything like this in that committee. And I think it is vitally important that the American people hear the facts that are being brought out at this hearing and understand them before we make, quite frankly, drastic, shocking changes to our current system. I also want to thank all of the witnesses. You are doing a great service. I think you're doing a service not only for the United States and for the American people who need to know this information, but for those of you who are not Americans, Dr. Sikora in England and the two of you here who are Canadians. You may be being criticized back home, but we can improve all these systems. The Canadian system obviously is looking at improvement, and your testimony here is vitally important. Ms. Holmes, I particularly want to thank you for coming to the my friend from Minnesota won't appreciate this, but he took a shot earlier. I want to thank you for coming to the clinic here in Arizona, the Mayo Clinic in Arizona. I have gone out there and talked with the doctors at Arizona. I do represent Phoenix, and they were deeply concerned about this level of reform. And as you know, the Mayo Clinic has now spoken out and said this, well, the American system needs reform. This is not the reform we need. Ms. Holmes, I want to ask you, your personal experience demonstrated both the failure of diagnosis under a state-run system and of getting the services you need as well.
That's right. I think I've turned it off. That's right. What happened to me, and this is why I feel my particular case is so genuine, because I took 3 stabs at the system for the same problem. So what I did was I couldn't get diagnosed, so I didn't even know what I had. I just knew I had symptoms. And I was fortunate, because quite often when you have a tumor inside you, you don't know what's going on. I was fortunate that there was very obviously physical things that had started to change with me, and the most obvious was my eyesight. And so when I traveled down to the U.S., it was boom, I got all the diagnosis. The thing that I found so remarkable about the Mayo Clinic, and I cannot say enough about the treatment that they give, was that the cooperation that they were prepared to work hand in hand with Canada, the amount that they were prepared to go in order to send me home for treatment and to stick their necks out to try and get me help back at home. I came home, I had that diagnosis, and it was, I think, more to their shock than anybody else that I was back on their door 3 weeks later saying, we need to do this, let's go. They never, ever looked at my bank account. They never said that, can you afford this? Let's do a credit check. Absolutely nothing.
Thank you.
And I think that's important.
I really appreciate it. Ms. Kerrigan, is that on? Just a quick question. I assume in your capacity, you're an advocate on health care and have been for many years. I assume you've read substantial portions of the House bill, looked at it pretty carefully. I was shocked last night. The president said a number of things in his remarks. I don't think he addressed the real concerns, but one of the things he said was point blank. He said the reform we're proposing will keep the government out of health care decisions. Is that an accurate or fair or even reasonable characterization of at least the House bill?
No. I mean, in short, no. It's the, if you just look at the, what is being set up from a federal government perspective in terms of, all the different departments, all the different offices, the new healthcare choices commissioner, the amount of regulations and just really, I think the amount of specific regulations that will make decisions in the system, it's quite extraordinary, in terms of the level of intrusiveness and also the level of intrusiveness on our sector, the small business sector.
The chairman cuts me off. Dr. Sikora, I'd like to conclude with you. The cancer statistics are pretty stunning. I've looked at them. If you look at the 5-year cancer survival rates in the United States, if you look at breast cancer, prostate cancer, or cancer in general, In all three categories, at 5-year survival rates, the United States beats Canada quite dramatically. It beats Europe overall by an even wider margin, and it beats England by an even wider margin than that. I'm looking at both the Concord study and the Eurocare study.
Right.
For breast cancer, it shows that the United States 5-year survival rate is 83.9%. The European survival rate is 73.1%, a full 10 points below that. And it shows that the survival rate at 5 years for breast cancer in the UK is 69.7%. As I listened to your earlier testimony, I think you used the word falling way behind.
Right.
Some, I believe, here in the United States will say, well, that's not because of the system. But I think I heard you say it is in part because of the system, both because of delay and because of access to drugs or treatment. Could you expand on that?
Yeah. I mean, I believe it. I've been studying this for the last 25 years, looking at why we're behind. What are the real factors? Now, there are many factors, and they're different in different cancers. The interesting thing about our statistics, if you look at the common cancers, the 4 commonest being breast, lung, prostate, and colon, those 4, that's where we're behind. If you look at the rare cancers, leukemia, lymphoma, testicular cancer, there we're not falling behind. So the NHS can provide the best care in the world for certain conditions. What it's bad at are cancers which are common and require access to general health care. So for these common cancers, you need to be diagnosed, you need to have access to imaging, you get access to a specialist. That all takes time. And then you need to have access to precision radiotherapy and good chemotherapy. And again, that may not be available for all cancers. So I think the reasons are very complex for individual cancers, but it's a total system problem rather than an individual cancer or individual skill problem. We have the skills, we've got the knowledge. It's just that the system doesn't allow patients to come in a timely fashion through it to get the best possible care.
I thank you very much for that. I hope the American people get to know those facts before we're forced to vote. I have just seen a report that says the Speaker of the House is, at least as it appears to report, is going to pull the bill from the Commerce Committee in order to get a vote next week. I don't know why the rush to judgment, but I certainly want to again thank you, Mr. Chairman, and thank all the witnesses. These are the facts the American people need to know before we vote on this kind of legislation.
Dr. Burgess.
Thank you, and thank you for doing this. For people who aren't aware, this is, I guess, the only active health hearing on the House side that's going on right now, even though we're told we're under a pretty tight timeline. And Shona, I know I've heard your testimony before, and it is always moving. I don't think I'd ever quite heard that wrap-up you gave about no one down here checking your bank account. And damn it, last night the president called us out as doctors and said we weren't seeing sick people. That's just flat wrong. And America's doctors and nurses have been stepping up and doing the right thing in spite of Medicaid, in spite of the abysmal reimbursement rates that are there in the public sector. So thank you for saying that. And I didn't intend to do that, but you forced me, and I'm glad you did. Dr. Sikora, can I ask you a question on the, if you could very briefly, and the chairman's got a tight gavel here, I know, can you very briefly kind of delineate some of the differences, as you're aware, between the medical justice system in your country and ours?
Yeah. It's regionally organized, and the referral path allows very little choice. You go to your GP, who refers you down a route that the primary care trust, the payer of care, has determined.
But as far as if someone gets in trouble and there's a bad outcome and there's a lawsuit that results, how is it different in the UK and in the United States?
We have much lower levels of litigation. Patients are much more compliant with the system because that's what we've been used to. That's what we've been brought up with. I think there's very little lateralism. Patients don't feel they've got the right to get second opinions, the right to move to choose a different pathway.
Is there a difference in the contingency arrangement, the fee arrangement that exists in the UK and the United States?
There are. For medical litigation, you mean, yeah?
Yes, sir.
Yeah, there are. It's coming. It's interesting how the two systems are coming together in terms of medical litigation, and medical litigation here is going up considerably.
Well, we're glad to export it to you. Unfortunately, we retain our own. Let me ask you another question. And John Shadegg was hitting on this. You talked briefly about the inability to meet innovation, and then in answer to Jenny Brown-Waite's question, you said not much has happened in a decade in cancer of the pancreas. And are there other areas of medicine where this has you see a stagnation of research?
I think it's when there's innovation, any area where there's innovation. I mean, the obvious one that affects many, many people is angioplasty for coronary artery disease. Immediate angioplasty after someone's suffering from a heart attack. Instead of delay, you go to a center where you can do the angioplasty and the patient walks out 2 days later and problem solved for at least a few years. And now that availability of that and the introduction of that was enormously slow in our system. Whereas in many systems where there's choice and competition, those providers that can introduce the innovation, that's where patients want to go. So they don't want to go to places where they can't get that innovation. No. That's the market, that's choice and competition, and that's what's lacking in government-run systems.
We're being accused of overutilizing that. Mr. Baker, just before I run out of time, let me ask you a question. I think you referenced the fact about budgets, and I don't know that people quite understand when we're compared with Canada. The Canadian system is on a budget, and when the budget is spent, the budget is spent. Our public system, and we have a much larger public system than you do, it is you send us the bill and we'll pay it no matter what. Now, we may reduce the amount, but there's no upper limit on the system. We just pay whatever comes across the counter. Could you speak to that for a moment?
Well, the budgets in Canada, each hospital has a block budget. At the beginning of the year, they're given, let's say, $6 million. They say, irrespective of how many people come, irrespective of the acuity of their problems, you must treat everybody within this budget. We don't care how you do it, just do it. Well, that's an impossible task. How can you set a budget without knowing how many patients you will have, without knowing what their complaints will be? It's an unworkable system, and we've seen it's not working.
Is there a contingency pool of funds that a hospital could go to if a patient like Shauna walks in after all of the money's been spent?
I'm not an expert on the budgets. I know that people do not get turned away normally if they have urgent conditions, but I will tell you that there's some conditions which you and I would say are urgent, such as urgent spinal surgeries in the town of Edmonton, Alberta. You cannot get an elective spinal surgery because they don't have funds to pay it. The only way to get a spinal surgery is go through the emergency ward. If you come to the emergency ward and you have soiled your underwear, you will get service. Otherwise, you do not get it.
See if I can get this mic back. I believe it's on. Well, thank you, Dr. Burgess. Thanks to our panel. Dr. Sikora, thanks for being with us from the UK. Shona Holmes and Richard Baker, thanks for your efforts to be here from Canada. Karen Kerrigan, thanks for your continued efforts for small business and entrepreneurship. Just a couple of concluding points. One is we've worked hard to come up with alternatives that we think would make this system work better. Dr. Sikora said repeatedly a phrase that we've been using. I'm not sure I've got it quite as concise as he did when he consistently said competition and choice drive value. We want more market factors in the system, more choices, more opportunities to choose your doctor, more opportunities for you and your doctor to choose your health care determinations. But we think we can have a system where people have many more choices than they have now. Karen Kerrigan talked about that, as she has, and small business folks have for years, opening up this system to where you have all the choices you have now, but you have choices beyond that. And inside the healthcare system itself, things like medical liability reform, more healthcare transparency, more health IT, all save money there as well. We want to see Americans get better health care and pay a price that they feel better about because it's driven by competition and choice. What we don't want to see is the elimination of choice and to come to the kind of government-run system that we've seen discussed here today, and not just in Canada and the UK, but in any country that has a government-run system. They all have rationing, they all have lines, they all develop some kind of two-tiered mechanism That's not what America wants, and we're going to continue to come forward with alternatives that we think solve these problems instead of make the problems better. So to my colleagues, to the audience here that patiently stayed with us through votes and microphone challenges and other things, and particularly to our panelists, and particularly to those who traveled or stayed up later in the evening in Great Britain to be with us, we're grateful to you. Thank you, Doctor. We're going to hang up the phone here. Thanks.